Jill comes to the office. She's in her young 40s. She could be any of us. And she's pretty discouraged. She's a pretty low maintenance girl. I mean, she doesn't need a lot of pats on the back to get the job done. She's got a couple of kids. She's trying to get to college without killing them. She's trying to get the laundry done. And she something's happened to her recently. She finally decides to go to her gynecologist. And she says, 3 things are happening, and I feel like I'm going crazy. The first one, her periods are really heavy suddenly. They're 10 days long, and it's inconvenient and it's uncomfortable. And she can't explain that. Nothing's really changed. Finally, she feels like she's wearing her heart on her sleeve, and her kids are pushing her buttons in a way that has never been able to do that before. It's just not like me. And a couple of days at work, she snapped and bit someone's head off, and that's just not like, she didn't even know where that came from. And then finally she says, I simply can't sleep. You know, I can go to sleep, but I can't seem to stay asleep. Where a gynecologist kind of placates her. She feels like he's dismissive or she's dismissive. And he does draw some labs on her, only to let her know that all your labs are normal. He offers her 3 prescriptions. 1, he offers her something to help her sleep. Secondly, he offers her birth control. Now, she's finished growing her family, but this birth control, this will help to stop that bleeding and control that. And then finally, he offers her an SSRI, one of the most famous antidepressants. And to her credit, she says, you know, I'm really not depressed. Something's really wrong with me. And so she leaves there kind of discouraged, and luckily she finds this, and now she is on a wholesome, bioidentical, oral progesterone that is $20 a month, and she feels free. But she is like many women, and her situation was absolutely predictable. And this is what we do. My name is Mandi Snell. I am the owner and founder of Solutions, and we help women and men find where they are located on the map of their hormone health. Now, this week is the 2-year anniversary where I stepped into this 800 square foot location, and I text Jennifer. And I said, do you think I can afford this? And JQ had been mentoring me for several months by then and teaching me the vocabulary of small business. And thanks to her, now that square footage is now doubled. We have 5 employees. We have 700 active clients. We have 12 to 15 new patients every week. And we've just opened our first satellite solutions in Nashville, Tennessee. Oh. Thank you. Now, in a setting like this, we're expected to network and to learn each other's business from mutual growth and referral. And while I would love one day to meet with y'all individually and services that we offer at Solutions, that's not the goal of this talk. The goal of this talk is to serve women in business and their health and wellness. So, but honestly, if you know me, I'm not going to be able, ooh, there it comes around. I'm not going to be able to hide what I'm really passionate about. And when it comes to health and wellness, when Emily Conley asked me 2 years ago, so who's your target market? And I naively but enthusiastically said, everybody with a heartbeat. And she laughed at me. She said, we're going to have to narrow that down. Well, I understand better now what she was talking about. However, with that same enthusiasm, this catechism of healthcare matters to every human. Why? Because we live in a fallen world, right? And where the decline of hormone is absolutely predictable, and it precedes chronic disease, always. This matters to every woman because we live in a domino effect as women. We have absolute guaranteed inescapable deficiency with predictable decline, which leads to symptoms, which precedes disease, and it's under-acknowledged until the last series of hormones finally fails us in the 5th decade, and we have a name for that called menopause, but the actual changes begin at least 2 decades before that, at least. So it's the mission of solutions to empower women to self-advocacy in a time of history where hormone health is undervalidated. And this matters to business women because we have a unique calling, we have a unique set of demands upon our body, soul, and spirit, and we can't rise and shine necessarily in the environment of angst and exhaustion and fatigue and insomnia. So I hope that this blesses you and acknowledges you and validates you in a way that serves you really well. All right, we can't avoid it. So in the name of being comprehensive, we can't bypass this subject. I do not project myself as an expert on diet or exercise. I refer my clients to people who I think that they are, but we will see clients who want to replace deficiencies in hormone apart from the obvious and necessary need for movement and the obvious and necessary need for good food choices. And because without that, they're more likely to fail because these things can't be separated from hormone health and wellness. A clinical pearl, if I had one clinical pearl, I would tell you that I would invite everyone to explore. It would be intermittent fasting. A lot of people go to the purpose of intermittent fasting for the purposes of weight loss, but they stay there for all of their non-scale victories that happen. Even most modest intermittent fasting, which is 16 hours or 18 hours. Really, this is just nothing more than dropping one meal and a coffee or a snack. It is not hard for business women to miss a meal because we're just busy. But modest fasting, of course, it preserves muscle. It increases your growth hormone 300%. That's unheard of in women in our middle age. And what does that do? Well, it literally lengthens something called telomeres on your DNA, which reverses aging. And so there's so many treasures to be found in intermittent fasting. If you were genuinely interested in two particular pieces of literature that I recommend for that. One, if you're a science geek and you like a deep dive, I recommend the book Obesity Code by Jason Fung. It is a deep dive. It's an outstanding book and textbook. A terrible title. There are a lot of people who are not obese who need to read his book, and I'm going to tell him one day. Then then there's Jen Stevens' book called Delay, Don't Deny. If you want to put your feet up one afternoon and read that book very carefully, it's written on a third grade level, and that is really his book rewritten very, very simply. So, of course, let's talk about supplements for a minute. Why do we take supplements? Well, because we live in a fallen world with fallen food that is grown in no longer mineral-rich soil, and we'd be naive to assume that our soils and commercial food are mineral-rich. Well, how do you take them? I tell all of our clients, there's rare exceptions, but not in the hormone context, to take all of them with a meal. Our grandparents taught us, you are what you eat. Well, actually, functional medicine says no. More specifically, you are what you absorb. And that's not the same thing. And so our guts are fallen, and we are not the same health in our gut as we weren't. But if we can consume our supplements in our meals, hopefully we're creating an atmosphere where our body will recognize it as food, and thus we'll have a better absorption. The things that my husband and I do to get 90 essential nutrients is pretty embarrassing, and so I try not to obviously overwhelm clients with all this litany of things that I would love for them to do. But when they ask me, and if you ask me if there were anything that I would tell you is super important, there's a few things I would not be able to escape. And number one is vitamin D. Vitamin D is the top of our treatment plan for every single client that comes to us. There's a lot of reasons for that. Immune health taught us that, for one thing. About 9 months after pandemic began, this anecdotal data showed that all of those people who had vitamin Ds greater than 50 were just never hospitalized with COVID. You remember when vitamin D just disappeared off the shelf during pandemic? Well, this is the data that led to that. I'm going to tell you, in 8 years, I've only met 8 people who had vitamin Ds naturally that high. Those are unicorns. So its role in immune health, very obvious to us at that time, but also hormone health. Vitamin D has some secrets. It behaves like a hormone. It doesn't behave like a vitamin. There's this process we talk about a lot in the office called aromatization. Cholesterol morphs into these wonderful messengers that go to our receptors and talk to them, and the whole process is sponsored by vitamin D from beginning to end. And we talk a lot about thyroid conversion. Thyroid conversion, there's a lot of people who've been told by their doctor, not hard to find, where their doctor said, your thyroid is just fine. That brain fog and weight gain, it's something else. But guess what? Their vitamin Ds are so low that they cannot convert their thyroid hormone to the active form that actually makes them feel well. So, so what I tell clients is, listen, until the Lord comes back and makes everyone whole again, there's a couple things we have to do, and vitamin D is one of them. So if I could ask you to do that, I would invite everybody to discover B vitamin combinations in the methylated form. Most of our clients, this is a pretty astute group of people who come to Solutions. They're well educated, they care about their health, or they wouldn't be in our office. And most of them, in spite of all the things that they're doing, live between 300 and 500 on their vitamin B12 level. And if you look on the right side of the page on LabCorp, it will tell you that you're just fine. But functional medicine says no. No, you're not even, your goal is to be a minimum of 800 on your vitamin B12. If most people need to supplement to be have a B12 of 800, and they do, the problem with that is that the most common B12 on the market is something called cyanocobalamin, which is a synthetic. That is only okay for 40% of the population. If you've not yet heard of MTHFR polymorphism in the literature, in the forums, you will really, really soon. And what that means is that we've discovered that 60% of Americans have some degree of genetic error that hinders their ability to turn vitamin Bs from their food or synthetic vitamin into the intracellular usable space in the cell. Intracellular vitamin studies aren't easy to come by, though I hope that Solutions is offering them this year. But what we're finding is that these patients in traditional medicine, particularly women who've been labeled and sent home with usually antidepressants and other labels, and these not cause diagnosis but effect diagnosis of fibromyalgia, chronic fatigue syndrome, chronic pain syndromes, what we're finding is they're actually in the intracellular space, vitamin B1, 6, 9, 12, and other B vitamin deficient. Methylation is the superpower of the liver, and it's the difference between two people. We all know these folks. They both have toxic American diets. They both have their doctors telling them, you have normal labs. But this person she has like healthy hair, healthy skin, her joints don't hurt, she sleeps fine, her mental health is not off the rails, and her clothes fit. But the other person, she has completely different profile, and she just feels like her life is snake bit, and she doesn't know why. The difference between a lot of these women profiles are one of them's methylating and one of them's not. So until you know that you have one of these genetic errors, you're in great company, 60%, like we said. You can bypass the issue by making sure that you're taking B vitamins that are methylated in those forms. Methylcobalamin, if I didn't write that down for you, methylcobalamin is the most common form of B12 instead of cyanocobalamin. It's not hard to find, but it will take some vigilance to check your supplement facts on the label. This is one of the shots that we offer at Solutions. It has 5 methylated vitamin Bs, it has 4 amino acids, and actually just compliments the artwork, compliments to Big Echo Creative, who branded that beautiful. It's a very popular shot at our office. And finally, on a brief subject of supplements one more time, if there was other common deficiencies, if you said, Mandy, if you were going to level up and do the next thing to ensure no deficiency, what I would recommend is mineral. The macro minerals like magnesium and zinc, we're deficient across the board as a country, but also the micro ones, the weird ones that don't get a lot of press. Selenium, molybdenum, copper, boron, vanadium, chromium, iodine. These things have roles in the enzyme health. It's not, we're not able to do a simple serum value and determine if you have deficiency. These are intracellular observation. And of course, our patients learn a lot about things like selenium and iodine to learn their role in their thyroid health, because we as a country have lower, our T3 hormones that actually help us to feel better with less brain fog, anxiety, depression, weight gain, inability to lose weight, constipation, dry skin, hair loss, and fatigue. Those numbers were actually 30% higher in 30 years ago. And so that explains a lot. But actually what I really want to do is I want to talk about women. But this is about being a woman. Menopause has these stereotype symptoms. What are they? They're hot flashes, night sweats, vaginal dryness. That's the last one. Actually, in the literature, joint pain is more common than all three of those. And I also want to talk specifically about a famous study in the 1990s that was about menopausal women. And I want you to know that this study and the outcome of this affects every woman in this room, no matter what your age. So the North American Menopause Society has told us that the common age for menopause, which of course is really just named as that's the last hormone to go, that's estrogen, around 51 and a half. And estrogen is just the last one to go, and it has these famous markers for it. But I would love to give y'all just a simple high school biology lesson about its sister hormone called progesterone. In fact, this is the subject that is so important to Solutions. We're determined to change the industry on this, and it will be the legacy of Solutions office that will make progesterone healthy, bioidentical, affordable progesterone to be a first-line drug of choice in mental health and breast protection for women, and it's underutilized in the industry right now. So this orange mark is estrogen. And at the beginning of our menstrual cycle, you remember this picture from biology in high school, right? So estrogen rises here, and this is blooming and blossoming your endometrial layer to make a nest for pregnancy. And then progesterone comes right behind that. Where this comes from is from an ovulated ovary, and there's this surge of progesterone that rises. Right here, in this moment, this is our fertile week in our menstrual cycle. This is a unique happening. When progesterone is rising right here, it has multiple jobs in the body, and most of them, by the way, in a woman are above her waist. But right there, below our waist, what progesterone is doing is it is countering this endometrial blooming, put some control and checking that. The nest is built and it stabilizes this blooming. But what it's also doing here in our brain is it's doing something, it's saturating GABA receptors in the brain that make our mental health far more stable. If you've ever noticed during your fertile time of your menstrual cycle, your skies are bluer. You wake up in a good mood. You unload the dishwasher like Snow White. You can't even explain it. Your libido is higher, you're smiling at your husband, and you get along with your kids. And you may not even know why. In fact, if we were to check your serum value, this is considered a high value, 15 to 20. If you get pregnant in this moment, your progesterone now goes to a very high 100, it soars. They call it progesterone, progestation, for a reason, but it's not just for pregnancy. Pregnant women are the what's the word I'm looking for? The poster child for mental health and progesterone. Pregnant women are what? They're very sleepy people, right? They have very low depression, low anxiety, low ruminating thinking, they don't have OCD behavior, and they don't go in the dark hole in their mental health. Why? Because they're saturated with progesterone. In fact, this is a good segue, understanding that many women, of course, pregnancy is marked with all this progesterone. Women deliver, and then the progesterone naturally falls back down, but guess what? Many women do not rebound. There it is. That is postpartum depression, absolutely. It is not spiritual. It is not fatigue. It is postpartum depression. In the Middle East, they give every female bioidentical progesterone at 5 and 6 weeks. They do not have postpartum depression. In North America, it is not treated with that. It's treated with SSRI, which is not fruitful. So here we go. But let's go back to this diagram. We don't conceive this week, and our progesterone naturally just falls and withdraws. When it withdraws from our uterus, it breaks that down, and it literally destabilizes that nest. It falls and literally falls and becomes our next period. But it also withdraws from our brain, and there it is, this low moment. This is a moment progesterone withdraws from our brain, and guess what? Here we are, premenstrual syndrome, also known as premenstrual dysphoria disorder, which is now an ICD-10 code. And this is absolutely, again, it's not spiritual. It's not the devil, it's you. We have our daggers fly out of our eyes, and our buttons are pushed easily, and we're irritable, and we don't even know what happened to us. And you know, if our husband might say, honey, what's the matter? If you're honest, I don't really know. But if you ask again, it's going to be you, actually. So the problem with that is that even though estrogen loss is around 51.5, guess what? A decade before that, you don't have progesterone any longer. Why? Because progesterone only surges from an ovulated ovary. And you're not consistently, if at all, ovulating after age 40. You know who else doesn't have progesterone? Women on birth control. I place every female after age 40 on progesterone every night for the rest of her life. And she has, also, what else does she have problems with? She has trouble with sleep. And she's needful. And then a decade before that, guess what? We're losing our testosterone at 1 to 3% a year. And of course, we're going to touch on testosterone a little bit longer. So we've got these 2 decades before menopause. Before we get hot flashes, night sweats, and vaginal dryness, we have what? Brain fog, anxiety, depression, weight gain, inability to lose weight, constipation, dry skin, fatigue, low mood, low motivation, poor mental focus, poor memory, low libido, insomnia, and joint pain, just to name a few. Now, if you are vulnerable in front of often an internal medicine or primary care provider in traditional medicine, I'm not throwing them under the bus, girls. I've been this provider. What's the most common prescription prescribed for this? It's antidepressant. And a lot of antidepressant. And guess what? It's not even fruitful. I don't judge women who are on antidepressant. Guess what I do? I put them on progesterone. And guess what? It's more fruitful. I had a psychiatrist who wanted to take me to the mat the other day. He really doesn't know who he's dealing with. And I just looked so sweet. And his wife turned 40 years old, and he had all these questions about progesterone. He's just a sheep like everybody else in the medical industry. He thinks progesterone is the same thing as progestin that causes breast cancer, clot, and disease. And so he wants to confront me about prescribing this for his wife. I'm so glad. So I'm going to be a lady, of course, and we're ready. You know what? When you have so much misunderstanding about hormone, you have to be prepared with a bigger sword for this Goliath. And we're up for that because we do want to change the industry, because progesterone is rarely prescribed and it's not a first-line drug of choice for this. And this deficiency is ignored as significant as it is. But anyway, she had even told him, of course, naturally he had prescribed SSRI for her. And she's like, and that wasn't fruitful. And she said to him, like, aren't you tired of seeing me miserable? But anyway, he had a lot of questions. I'm so glad. I welcome that. The people who kick the tires on this science become the smartest people and are the biggest advocates for it. But when he got done, he couldn't wait to get her started. And I told him as politely as I could without being, rude, that the trouble in mental health is that you can't validate that on labs in a lot of ways, right? And I was willing to tell him, listen, my safety profile and my outcomes are better than yours. I'm happy to say it. And he knows that because he's in the industry and he knows that his patients are not responding. Gary Brecka said something the other day. Gosh, I was like, I wish I'd said that. He said, he was asking somebody about how long have you been on SSRI? And then someone answered like a decade or something like that. And he said, well, when did you think it was going to start kicking in? And I was like, so not to sound like too much bravado or any disrespect, but I've been a nurse practitioner this year 30 years. Thousands of people. All my symptoms got better when I started taking SSRI. Said no one ever in my career. Never. So, and they're hard to get off of. We have to be careful with that. But anyway, so why does all this matter to me? because there's a gross, like we said, even negligent understanding of hormone. And most of our adult lives, we have learned from the medical or even non-medical sources this catechism that hormone replacement therapy is risky, causing breast cancer, clots and disease, and stroke as a result of clot. And we're going to talk about that subject and where that came from. This subject causes a visceral reaction in the medical industry in every specialty whatsoever. But what is the truth? The study that led to this drastic conclusion is referred to as the Women's Health Initiative of the 1990s, or WHI, as you'll hear me refer to it. WHI's, guess what, been rescinded and debunked completely 6 years ago. But the industry hasn't changed yet. Not yet. And we live in a time when you have to actually learn how to advocate for yourself, to know the language, kick the tires on those studies and figure this out, because you may not be greeted in some of the traditional medical spaces with the ability to recognize this as a hormone problem. So to go through that, March is National, the Women's History Month. And so kind of in the spirit of that, we're going to go back to our 1980s. We're going to start there. So our mom's generation faced menopause with something called Premarin. Anybody remember Premarin? So Premarin was something that, it was an estrogen. Estrogen was not available yet in the human form, and this was made out of pregnant horse urine from mares, and thus the name Premarin. And it was as a synthetic. A third grader could look at these two molecules and say, boy, they're really, really close. And women did really quite well on it. There was this mantra of the 80s, though, was this thing called the shortest dose for the shortest amount of time. And this wasn't really used for disease prevention. We learned that within the decade, that this wasn't used as disease prevention for prevent osteoporosis. This was a hush puppy to quiet women who were experiencing hot flashes, night sweats, vaginal dryness, and to get them through transition, and then you just kind of dropped it for them. But women wouldn't let go of it. And they started to recognize that women who were on Premarin had actually a lot less disease. But this was a synthetic, and but again, it was really something that was working quite well. And it was undeniable. By the 1990s, they used this term called the critical window. Do you know the critical window theory has been used in gynecology offices last week that I know specifically of, as though that is legitimate terms. It's actually very old news. The critical window was they really didn't know where was the end of the earth with hormone therapy. And so they said, if you don't start it by age 60, it's too late. And once you get to 60, you need to take it away from women, because they didn't know how long this was going to be a good idea. But the decrease in disease and they had less bone loss, they had less vascular disease, less heart attacks, less cancer, and less dementia. And so thus they needed to figure out, like, what does this have to do with this? They said that you could look at a woman and tell her if she was hormone replacement therapy. And so we needed this randomized trial, a prospective study. And thus the Women's Health Initiative was born. Women's Health Initiative was sponsored by NIH. It was a $625 million grant, and it was going to be thousands and thousands of women from coast to coast for 8 years. And it wasn't a bunch of bad guys. It wasn't recognized that the study was grossly flawed for a lot of reasons. What we had is we had Premarin, and we had Prempro, and we had anecdotal observations that women were just simply healthier. How long was this going to prevent chronic disease? We didn't know. That was the goal of the study, was to observe chronic disease and long-term use of that. So there were only two groups. They were all menopausal women. First women, the women who had had removal of their uterus. They'd had hysterectomies. They were in group 1. They used Premarin. This was, of course, a synthetic estrogen, and that was what they used. And of course, it was oral form. And then there was group 2. There's a group of women who were menopausal but still had an intact uterus, and they had to use a double drug. They used Premarin, and this synthetic progesterone called Provera, or a progestin, And this was to make sure that these menopausal women didn't bleed. Both were synthetic. In 2002, 5.5 years into this study, there was a spike, an incidence of increased clots and breast cancer, clots in the form of stroke as well. This was a randomized trial, is a prospective study, which means that you had to inform the second arm of the study that this was happening. And that arm completely stopped. So progesterone, we talked about, is the good guy. Now, in the industry, progesterone, the micronized bioidentical form, wasn't even available until 1998. It was behind that. The people who sit in the seats of power in the American College of Obstetrics and Gynecology, they weren't even in residency any longer when progesterone was available. Before that, it wasn't capable of being made. But this is breast protective. We, again, like I said, our determination is that this is going to be a first-line drug of health, for mental health. It's also breast protective. We'll speak about that. It's sleep supportive. You have less anxiety. It's mood elevating. It reduces risk of clot and all stroke, and it prevents osteoporosis. Isn't it just like God to put something like that in us? Progestin is not the same thing as progesterone. In fact, I had to walk the floor the other day. I had a patient, of course, Mirena's are an IUD, and they're progestin coded. And one of our clients, she approached her gynecologist. She heard from our receptionist, Ashley, about the incredible things, all the things that progesterone has done for her. And she went to her doctor and said, you know, I think I want to have some of this progesterone stuff. And the doctor told her, that's the same thing that's on your Mirena. It's not. And I just have to walk the floor. Other names for MB, and I had another patient tell me, I'm on progesterone, by the way, but she couldn't remember her dose. I said, just send me a picture. Just send me a picture of that and we'll know what your dose is. Guess what? She thought it was progesterone because her doctor referred to it as progesterone. It's actually its MPA with its methyl hydroxyprogesterone acetate. That's progestin. So glad she sent the picture. And if that's not enough problem with the industry, when I prescribe micronized progesterone for clients, they walk out of Walgreens and they have this stapled monograph in the little white bag stapled to that, and they have the correct drug, but the monograph attached to that is, this is a progestin class, and goes on to list all of the risks of clots and disease and that sort of thing. And so that is a problem that happens in all of our big box pharmacies. But it also has other names, norethindrone. All birth control has progestin in it. And of course, I mentioned it renders the body's progesterone to be zero. Progesterone, however, is bioidentical. It's available as an oral generic for $20 a month. It prevents premenstrual migraine. Remember that same dip in our progesterone that happens right before our period, premenstrual migraine? Progesterone actually helps that. It's the functional medicine world that's saying, listen, progesterone doesn't have the clinical indication for headache, but it should. It doesn't have the clinical indication for anxiety, depression, postpartum depression, insomnia, but it does all of these things and so much more. In fact, one of my mentors, Dan Purser, calls it the feel-good hormone. So, of course, we've mentioned these things as well, but progesterone is a lady protector. It is not a coincidence that progestin group got breast cancer. Why is that? Because progesterone protects the breast. That's one of the things that it does in these receptors. Most of the work of progesterone is above our waist. We know that women who have progesterone over the more years of their lifetime have 70% less breast cancer. Women who have higher levels of progesterone over their lifetime have 540% less breast cancer because of its protection. So how do we know that? Was it just the lack of progesterone, or was it the progestin? Which one's the problem? It's both. And how do we know? Because those women in the WHI, the average age for them was 62 and a half. These girls had not ovulated for 20 years. They'd been progesterone deficient for 20 years. And then we added progestin to a receptor where it doesn't belong, and now we've induced a problem. So can you see that? It's not a coincidence. So it's a lady protector. And of course, it decreases the risk of death from all cancers. And even this, now this is controversial. We know that natural progesterone actually causes what's called apoptosis. It pops breast cancer cells. did I just say that progesterone treats breast cancer? There's a few people saying it, and there's some concern about those people being censored. Why? Because it's not a very lucrative breast cancer treatment. So anyway, there, I said it. If something happens to me, I am not suicidal. I just want you to know. So that said, so this is one of the things. I encourage all of our clients that this is a time to be a self-advocate. We're going to be ladies. We're not going to fuss at our doctors, but we're going to shake hands and say bye, and we're going to go to the next person if we can't get the help that we need. This is a part of the industry's problem. Your gynecologist hasn't had time to read anything in the last 6 years. He or she is double and triple burked. Have you ever gone to a gynecology office and gotten out in 30 minutes? No. No, you haven't, because these groups are now part of the they are now employees of the hospital system who are together with the insurance company, and there's some incentives in that. And so this is just a time for you to learn. So I tell everybody to buy this book. Buy 2 of them, one for you and one for a sister that you know is in the same boat, so that they can become equipped. And this is a simple unfolding of the WHI data called Estrogen Matters. And it's a really wonderful book. In fact, I have everything here is free. It's first come, first served, but I brought some great materials there if you like them. But while the WHI was debunked 6 years ago, still 70% of women in perimenopause, which is, guess what, 8 years before menopause, when you start to have these symptoms on and off, but you're still having menstrual cycles, 70% of women are not being treated. And self-advocacy is necessary. I have clients who are 57, 67 years old with disease and chronic pain, with severe, like a spinal column full of compression fractures that estrogen will not fix now. And guess what? They've never received the conversation. It's never even been brought up. And they're maybe too timid to bring it up themselves. So not our girls. Great news, y'all, though. There is a congressional bill that was presented to Congress on December the 13th. You can look at letstalkmenopause.org and start learning about this. This is a bill. It's going to take a decade. Remember, NIH, this was $625 million to do WHI. This is going to take a decade, but the goal of this is to first do a new study, an excellent study, and to re-educate the well-ingrained medical establishment and make this mainstream. The Menopause Research and Equity Act of 2023, so there is hope. But guess what? Some of us in this room, we don't have time to wait for that. So if hormone havoc, I'm borrowing one of my mentor's terms. She wrote a book called Hormone Havoc. So back again, a recap. Estrogen got the blame that it didn't belong. Progestins didn't get blamed enough and are used too fearlessly and recklessly, perhaps. And then progesterone not used enough, underutilized, and then testosterone completely misunderstood. And for a lot of reasons, it has a real public relations issue. One of our second goals is to make healthy, trace, feminine doses of testosterone available to women and take away the taboo of that, and it has to be done well. This is what, it's the man's hormone, right? We consider this to be a man's thing, and of course we associate this a lot with anabolic steroid. Providers will think, now won't that cause you to grow a beard and lower your voice and to grow an Adam's apple and all this stuff? No, no, no. That is data extrapolated from anabolic steroid. Testosterone doesn't even do that. But if you can do this incorrectly, if you give a woman testosterone in a dose that doesn't belong to her, that belongs to a man, she will change her body shape. Her shoulders will become a little broader after about 12 or 14 months instead of her hips. And that is a desired effect sometimes in women's bodybuilding, but that's not my clientele. The problem with that, and so I'll say this gently, the problem with, it's not FDA approved for women at all, and that's not okay. Because while our doses and our serum value of testosterone is very low compared to a man's, very low, our ratio of testosterone to estrogen for a man, compared to a man's, is much higher. And it's not FDA approved for women at all. And that's unfortunate. Those people who do recognize testosterone as an anti-inflammatory, as an antioxidant, as a vascular protector, muscle preserver, mental health drug, have to therefore access this stuff through medical sceneries and clinics that are not very academically driven. Their target market is usually aimed at people who are looking for anti-aging, which is not incorrect. But the only difference between medication and poison is the dose. And so we're at Solutions trying to make sure that our branding is recognized as a think tank and not a non-academic setting like that. So the myths about testosterone, I think I've talked a little bit about. I mentioned the mental health benefit of testosterone. It is not hard to find a woman who is testosterone deficient. In fact, all testosterone values are half what they were 40 years ago. We have this acronym we use at the office called the M's. Testosterone elevates your mood, elevates your motivation, your mental focus, your memory, your mojo, which is a ladylike reference to libido, and it's a malaise reliever. What it sounds like in the speech of women is, you know, honey, that garage that we've been hoarding in for the last 3 years, this weekend we're turning that into an office. And she just has the gumption and the ability to go through all the process. That is what testosterone therapy can look like. So, case study, this is Julie. I've talked about her already. Honestly, I mentioned her at first. So here is Sandy. She's 35 years old, and she's had this increase in her anger and irritability, increase in anxiety, depression. She's been placed on SSRI. It's not done anything for her. She's come to us, and we discover that she has an IUD that correlates with onset of her mental health disruption. Of course, it's progestin coated. The makers of IUD, Mirena, will tell you that, oh, no, it only occupies the receptor in the uterus. No, there's too much evidence to the contrary. There's many women who initiate their the IUDs, and the lucky women are those who, within several days to weeks, recognize my mental health is off the rails. And they discontinue this, and they go back to their baseline. I mean, they may not be whistling while they work, but they go back to their baseline. The unlucky women are those women who have been on progestin since they were children. And they have had their first decade of adulthood. By that time, by the end of that first decade of adulthood, they're usually on SSRI or a series of mental health medications to help them. And no one's ever suggested that it has something to do with them. And they feel like that they have something wrong with them, which is a lie. So, next case study. This is Kaylin. She's 25. She's 6 weeks postpartum. She was placed on SSRI at her postpartum visit, and of course her blood progesterone is nothing. We place her on progesterone, 100 milligrams orally at bedtime. So also, she is in such crisis, we also start her on a progesterone under the tongue to take at daytime, and we actually can save her life. We've had a client whose husband came to us in tears, telling us later that he had put his wife on suicide watch because she was in such crisis. We didn't know this at the time when we placed her on progesterone, but now we know that her life's been saved by progesterone. So this is Cheryl. She's 32 years old. She has normal menstrual cycles. She has a history of premenstrual migraine. If the migraine doesn't debilitate her, the medications that her neurology group has her on do debilitate her while she's trying for at least one entire day per month. Now she's on oral progesterone for the last week of her menstrual cycle, and she's free. And she has sat in our office and wept. Why didn't my neurologist do this? And I just have to comfort her because it's not in the differential diagnosis list. And here's Lisa. She's 48. Her periods are irregular. She's having hot flashes. But then again, maybe she's not. Maybe it's just the thermostat. She's just not sure because it comes and it goes. She wakes up in a pool of sweat sometimes. She's having some vaginal dryness. And last year, she started noticing that she can't go into her blazer with this arm. She's having to go into blazer with the other arm because her shoulder's just bothering her for reasons she can't explain. And her hips are hurting. And her gynecologist told her her labs were just fine. He offered her an anti-inflammatory for a joint pain and gave her a referral to orthopedics for a shoulder. The arthritis blood work that she asked for came back negative. But her lab work with us is she has a terrible vitamin D. And we've actually increased her vitamin D level. We've doubled that. We've increased her methylated B vitamin. She's methylating better. We've optimized her thyroid. She's now on vaginal estrogen while we await for full ovarian failure and start her on daily estrogen systemically, and she's on a testosterone cream. And she's doing better. Now this is Margaret. She's had no cycles for about 6 years now. She's having hot flashes, but no more night sweats. She's kind of over that, but her hips hurt terribly. She's got backache. She's forgetting things. Her mother had a history of breast cancer, and her doctor told her, you can't qualify for hormone replacement therapy. She's had painful intercourse. She's having lots of UTIs, and she has to get up in the night to urinate because this bladder just keeps annoying her, and she doesn't have an infection. They've checked her 6 times. And now, of course, we've talked to her and we've got her started on hormone replacement therapy, and now she's successfully prospering. And then finally, this is our last one. This is Kathy. She's a business owner and she wakes up tired, and her doctor said her labs were normal. She's not been successful in SSRI, joint pain, gaining weight. And so now her lab's low vitamin D, she's got a low B12, progesterone non-existent, testosterone non-detectable. Her TSH is normal, just like her doctor said, but her free T3 is in the 25th percentile. And now here she is with these routine therapies that are so easy and so wholesome and so clean. And now she's doing that. Now she's killing it. So where are you? Well, we can help you find that, but our theology of hormone health we want to wrap up is this. This is predictable decline. It was never intended by God. This is the result of Genesis 3, the fall of man. And so with that became this decline that starts to happen. And of course, we are no longer appointed to death in Christ. Therefore, this decline that leads to death, will we die? That is a certainty. However, we are judicially no longer appointed to death, and therefore we no longer have to consent to this decline. And so if God will give us healthy revelation, if we're good stewards of that revelation, then we can do some endocrine mimicry to bring life so that we can serve and be fruitful. And the thief comes only to steal, kill, and destroy, but he's come that we may have life and have it to the full, and which is a call to have hope, a call to advocate for yourself and for others. Of course, a call to study, learn the science, and find your own vocabulary there, and learn to speak in. Finally, a call to gratitude. And thank you very much.
Thank you, Mandi.
He's a Biotee, the founder of Biotee. I was a Biotee provider 8 years ago, and I learned, the first thing that I learned about hormone replacement therapy, I really learned from him. Yeah, I did. I'm going to write Progesterone Matters More.
The most.
Matters the most. Yeah.
You talked about blood tests. I'm wondering what other tests you do.
Our comprehensive panel includes CBC and chemistry. That's boring. Everybody does that, but we do it. Vitamin D levels, vitamin B12 levels, estrogen, testosterone, free testosterone, C-reactive protein.
Blood.
Yes. Sex hormone binding globulin, thyroid.
And the Dutch test?
The Dutch test is very popular right now, and it talks about saliva studies. If you are a hormone elite, you will not be satisfied with a Dutch test. Saliva is not accurate as serum.
It's urine.
Oh, with urine, once again, serum is going to be useful. But I'll tell you what's even more significant than serum is listening to your patient. Patients will tell you where their hormone is, and that is more significant. Doesn't correlate with labs in any form, and patients will tell you exactly what they need. And you just use your labs and those numbers to validate what they're already telling you in a lot of ways.
Okay.